So good afternoon, everyone. It's always hard to be the act after lunch, isn't it? Particularly when you've had an opportunity to go international. We do realise it's the after lunch slot, so there might be a lot of repetition, deviation, and all those sort of things, but hopefully not. Because here is our first speaker. The curtains are drawn. You're on the stage. Here to a round of applause is our very own, who is it? Chris Gibbs. Yeah, Chris Gibbs, on building a national network for dementia care research. So come and tell us how to do it.
Thank you, Jill. I'm going to start with repetition, I think. So I'm just going to talk a little bit about the applied research centres, and this is definitely somewhat of the parochial to the cosmopolitan, and it's also a little bit about gaps and challenges and opportunities. So we're all quite aware of this second translational gap, and it's a lot about what we've been talking on today. So the fact that there is knowledge and that there is practice, and there is healthcare science, which is quite often separated from healthcare service. And the ARCs are really designed to try and bridge that gap across health and care. So the mission of the ARCs is to try and improve outcomes for patients and public, to improve quality, delivery, and efficiency of health and care services, to increase that sustainability of health and care systems, and do that both locally and nationally. And so this is an iteration of a previous scheme called the Clarks, which I won't try and tell you the acronym of because it's impossible. And there are 15 ARCs that have been funded as of about September last year. They've each got a certain amount of money. They have to acquire match funding from local partners. And this is specifically designed to try and make sure that it's addressing the priorities of those partners. So essentially what they're doing in part is bringing together a range of people, of health researchers, of other organizations to focus on people and the communities in which they live. So it may be medtech, it may be local organizations involved in research, third sector, the NHS itself. But again, this focuses on local and national priorities. Now if we take Wessex, which is the region through Hampshire, Dorset and the Isle of Wight, it's an older population. There are top priorities in terms of healthcare need. This includes older people, multimorbidity, obesity, dementia, and workforce. And these are focused on our particular needs, which are actually a subset of the national need. In Wessex, this has been blended into 4 overall themes: an aging and dementia theme, a theme about workforce and health systems. There's a healthy communities theme, and then long-term conditions. But these are underpinned by a couple of other areas, which is very fundamental public and community involvement, and a need and a desire to build capacity for applied research, making sure that there's full engagement with all the partners that are in the region, and then translating research into action, which I think is, again, a theme that we've had today. So just focusing for a moment on the parochial, which is the aging and dementia theme in Wessex. So there are a couple of things within dementia. So our belief is that the prospects of people with dementia are improved by earlier diagnosis and joined-up care. And as a result, our work in this particular theme on that aspect of things is about employing diagnostic technologies to better effect, but also to use digital tools to help join up care. We also believe that patients have a better experience and their outcomes are better if they're placed at the center of decisions about their care. And for this, we're examining and testing and piloting better ways to support and train staff to help them improve that patient experience, promote their choice, and to give them a voice. So all of this across the different themes is designed to try and build applied research capacity. It's trying to accelerate the implementation of health and care research evidence into practice. And very specifically, it's engaging with the public and collaborating partners to do this. But that's the parochial. So how about the cosmopolitan? Well, we can scale this up nationally, but we have to have a structure and a system for doing that. So the ARCs across the country have come together, and not every ARC is interested in aging and dementia. Some have none of that in their remit, but actually most have something to do with one of these topics. So 4 ARCs have taken the lead in creating a structure. In Wessex, there's particular expertise in workforce and digital tools. In Greater Manchester, health economics and implementation science. In the Penn ARC, Southwest Peninsula, public and community involvement and engagement. And in Yorkshire and Humber, it's evidence synthesis and evaluation methods. And that's the kind of collective leadership group, but in fact, 8 other ARCs are involved in this structure. So this is still a proposal, it's not actually finalized yet, but essentially the process would be this, is that every ARC would hold a stakeholder forum, and that's designed to reflect the interests and the nature of the varied populations across the country. But these stakeholder forums are very widespread in terms of participation and representation. There would need to be regular meetings between researchers and stakeholders, and also engagement with the Academic Health Science Network. And many of these organizations within the NIHR and others actually work adjacent to each other, and there is the potential for handoff once the evidence is created from one area to hand it off to something like the Academic Health Science Network to then spread that innovation. Ultimately, what we're trying to do here is to identify and then prioritize things that have evidence, things that are solutions that then can meet specific needs and then be implemented at scale. So here would be the criteria for how any particular innovation would actually be scaled up. It must be innovative, and it must address a need from the NHS long-term plan. We've already had lots of discussions in this country about where the priorities should be. There needs to be high-quality evidence of impact in at least one region, because one of the requirements for the AHSN to take on things to spread further is that there is evidence in 2 regions, and so what we want to do is to create that bridge. Find it works in one place, show it works in another, in a different context, and then move it on. There must be some evidence of economic benefit, or at least a level of cost neutrality, and then there must be identification of the specific implementation barriers that need to be overcome, and some sort of plan to address those. One of the things that we know when we're applying things, when we're implementing things, is that commissioners require evidence to support that implementation, and we need to gather that evidence so that we give them a good case for doing things. And we need to have clear scalability plans. And one of the most important things is to identify and utilize communities of practice that will champion and embrace these, because they can't just land nowhere, they have to land within fertile soil. So this is the proposal that is being put through at the moment, and the aim is just to use these ARCs collaboratively to try and screen these proposals and then scale them up. And I've just given you a list of the groups that are currently involved in it. So thank you very much.
Great, thanks, Chris. And we're hoping that the ARCs involved in social care will be very much involved in these networks. We apologise to our colleagues who are in Scotland, Wales and Northern Ireland who are sort of left out of the ARC, but you're very welcome to join 1 by 1 or 2 by 2 in whatever constellation appears. I know, it's me, yes, just one. So, good. So I've been asked to look at networks, and I'm building on a survey done by Nicola Hart. So thank you very much, Nicola, for providing the data for this, which is about what people might want from further collaboration and networks. And I'm hoping the slides will appear like magic. If I press the button, great, lovely. On building national networks for dementia research. And as you can see, we're particularly interested in the links between researchers and end users of research, and between research funders. And that's the information that Nicola so ably gathered together. We've heard today already about a very powerful research network. And I don't know who thought of the idea of calling it a network, but they were very much ahead of their time 20 years ago in saying that this was going to be an important network. And interestingly enough, did not choose to use the word patient or public or any of those troublesome words, but set out a very helpful term in terms of, for us researchers, of calling it a research network. So many people here will have worked with Alzheimer Research Network volunteers and drawn a lot from their experience, their expertise, and so on. And most of us researchers, I have to say, will always rely on the Research Network volunteers to remember which project we're talking about, what the proposal actually said, and what they're doing in the particular meeting. So thank you very much to everybody involved in that. The second existing network that many people have been involved in, and people are represented here, I see Adam Smith sitting probably tweeting away, is the Dementia Research Network, which has had a powerful impact, hasn't it? And 20 years ago, we probably wouldn't have thought of the ways in which social media, blogs, podcasts and so on would engage with so many people, both here within the UK, but also internationally. And I think really it would be very helpful to build on plans for the future of this network, rather as networks can do, which is slightly fade away if the resources aren't there to support them anymore, or people move on. So if you don't know about this, if you don't count yourself an early career researcher anymore, please look there, and you can disguise your presence. And the third one, mentioned many times, has been the Enrich Network on enabling research in care homes, and how welcome and receptive the care home world, I think, has been in most cases to welcoming researchers across its threshold, to finding them very helpful. Nobody talks about ivory towers or anything like that, but really building that. So from Nicola's research and our own look at those networks, what seem to be the common themes? And the first of them is oxygen, mostly referred to as resources, that there are very few networks that appear to work just on goodwill alone. They need resources for the most prosaic and mundane of things, but also to keep things going when perhaps enthusiasm is flagging or there appear to be too many other jobs in the day. The second, I think, is this notion of them having some sort of shelter or home, and to be able to have a location which appears to be solid, so that the website works, so that things don't crash, so that hacking doesn't happen, and so on, and how valuable that's been within the NIHR in particular, but also within the society, and maybe many other research funders would think about that as being an important part of their role, is to provide a home or shelter. Third is time and commitment. Many people assume that everybody's got an enormous amount of time free in their day. We're not quite in the position of many commercial researchers, in which we have to account for every 5 minutes of our task, most of us in this room, perhaps not yet, but really saying how much networking takes time and how difficult that is to capture. In my own university, they refer to citizenship as a rather quaint term for all this activity, but it's very hard to say, to build the evidence for the citizenship that one has, but also to remember that being part of networks obviously is part of this, and commitment. How many networks can we be involved with is probably something we could discuss on tables, but perhaps there is sometimes just too many and we have to prioritize or make choices. We've heard many times today the role of flexibility, and that applies, I think, particularly in localism. The Enrich examples that we looked at and that we heard about this morning, some of them flourish in localities, don't they? But other localities have other mechanisms. Our own area of South London has a very thriving care home research network, but it isn't labelled Enrich network. So there is a localism and perhaps an increasing regionalism around those debates. Not unimportantly is the notion of talent. We probably all know those colleagues of ours who are really good at networking. They're very jovial, they're out at parties, they organise the Christmas lunch, they're good at networking. But there are many people who are good at networking in other ways. And I suppose one of the things we've learned over the past couple of decades is that you can be a network person on social media without having to have those other more jovial skills that perhaps we think of as networkers. Lastly, I suppose, or penultimately, benefits have got to outweigh the effort, but a touch of altruism always goes a long way. So, just turning to one network that I think we probably need to pause and think about, what is the role of the Dementia Action Alliance there? You can see its members. Members being counted electronically are always universally wrong, so it probably is thereabouts 114. And thinking about that, when we see the list of people counted there, charities, social care providers, government bodies, pharmaceuticals, Royal College and wellbeing organisations, which of our own networks do not get in that list? Because I think there probably are quite some missing people there, and how we can encourage people to be both involved nationally, but also at that important local link, and thought needed there about how those local networks are working. So, the questions, this is the exam questions for us a little bit later on, so hopefully Dawn will come with the answers to them all, and then we can have an early tea. But we're going to be asked to think about what is strong in the existing networks that are around, what could be stronger, and how would we get there, And that's the question, the last one. How can we make things stronger? And in doing so, perhaps there are some networks whose time has come and maybe their time has passed and we no longer need to include them on our Christmas card list. So over to Dawn. I must be the only person today who worried desperately that somebody from the Department of Health or the NHR would realise that we hadn't put a disclaimer on things. So feel mortified if you've not done that. So here is my apologies that everything I say isn't the responsibility of the government and everything the government says isn't my responsibility either.
Thank you. Thank you very much, Jill. Wow, I'm not sure I can follow that at that pace. So my title is around building strength between academia and the users of dementia care research. And what I've decided to do is to talk through a case study of a piece of research which around meeting centres, which I think illustrates many of the things that we can try to put in place and perhaps that we can try to strengthen in our ongoing research so that it happens more regularly. But first of all, I think to just talk about the strength of our research centres. This is mine, Association for Dementia Studies at the University of Worcester. And I think like a lot of us in the room who are working in university-based research centres in this country, a lot of our work dates back to Mary Marshall and Dementia Services Development Centres, and that idea that dementia care research is actually multidisciplinary, multi-agency, that it is about trying to influence policy and research, and it's about getting research into practice. And I think that is one of our great strengths in this country, that is almost in the DNA of most research groups around dementia. I think what we also, I mean, certainly in my centre and many others, being absolutely trying to be inclusive of people directly affected by dementia. And I think over the last 10 years, we've seen some great strides in ensuring that our research is more inclusive and co-produced. We've still got a long way to go, but we're certainly off the blocks there. I think what we're not so good at is actually engaging with the users of that research, and that is the health and social care workforce, which is increasingly diverse. But again, I think we've got a great strength in many of our researchers in this area, in that a lot of researchers in dementia care have also been clinicians or practitioners or who have come up through the care workforce as well. So often we have many of the skills of being able to translate between those worlds. We perhaps don't use it as much as we can, but there is a wish to do so. Okay, so I'm going to talk about meeting centres. If you want to know more about meeting centres, I can talk about them for days. We've got lots of stuff on our website. But essentially, meeting centres provide local, community-driven, ongoing, flexible, person-centred support for people living with dementia and their family carers. They're provided by a small permanent staff team and volunteers trained to really help people and families cope with the challenges that dementia brings. So it's in that post-diagnostic phase that meeting centres would fill the gap. Developed in the Netherlands, they have developed a very good structured community planning phase that provides inclusive engagement from health, social care, voluntary organisations, community groups, and local movers and shakers. The original, the JPND funded research project that this built on, led by Professor Rosemary Dreurs from the Netherlands, where meeting centres have been going for 20 years or so. So the first piece of translational research here is there are things going on in other countries that we can absolutely learn about in this country. And this was a very nice piece of research that took the learning from the Netherlands to see whether we could introduce it into the UK, Italy and Poland. So three very different European countries. I'm not going to talk about the findings of the research specifically, but want to touch on things that were in that research project that I think have really helped us when we've been looking at knowledge exchange and transfer further on. Firstly, in each country, we had to develop pilot sites. And it comes back, I think, particularly in the area of social care, to Martin's point earlier, that finding the funding for developing those pilot sites was really problematic because this is social care treatment costs. We were very lucky in that the Alzheimer Society, particularly Colin Capper and colleagues, delivered those pilot sites for us. But if we hadn't had that, we wouldn't have been able to do the research. So I think that's our first key thing. We developed guidelines and toolkits. We also developed training for the staff who were delivering those meeting centres. So those were our research outputs. Interestingly, and I think that really helped, as part of the research funding, the Meeting Dem one, we delivered 6 national pioneer workshops around the country. So before the end of the research project, we were already travelling to people in their local communities, into the hotspots, and doing workshops. So when the research ended, we had a groundswell of interest who wanted to take this forwards. And we did web pages, social media, and we made some nice films. The next stage, and I think this might be something that we could think about taking forwards, was after the research funding finished, we actually applied to the National Lottery Community Fund to do some scale up. So this was a nice grant, £587,000, and this was to take the learning from our original research to try to develop 15 to 20 meeting centres across the UK. Now what that's done is fund a programme manager who works on full time. We can do lots more community workshops and deliver training. So that's our oxygen. It's also given us the ability to have to develop a national community of learning and practice and a national reference group of movers and shakers from Department of Health, etc., who can help to take this forward longer term. Now I'm just thinking, you know, for our good interventions, linking with National Lottery as a way of doing your scale up, we should be looking at those funders who can provide the oxygen to get this work going. And then more recently, hot off the press, locally, Worcestershire, as a county council, have just put £540,000 in to developing a network of meeting centres across the whole county. And that wouldn't have occurred if we hadn't have got the National Lottery funding. Because we have the National Lottery funding, we actually now have a home in which to form this very local network. And already, you know, we had our first kick-off meeting about this on Monday, 150 people in the room who all want to get their hands on some pump priming money to set up meeting centres within their local community. And we also had 2 neighbouring county council chief executives at that meeting as well. So it means if this takes off in Worcestershire, there's no reason why they can't do it in Gloucestershire and Shropshire as well. So my final comments, and I've been trying to think around metaphors, we all know with knowledge exchange that it's not a single track road. It's got to be a two-way street, and that two-way street means that we get our research findings into practice and really making a difference to people's lives, but also it makes our research better and more relevant. And the two go hand in hand. It's not one transferring to another, it's about that exchange. It improves our care and our research. But at the moment, you know, when I think about how it feels being a researcher, it can almost feel like I'm in a 5-track highway. You know, there are so many different streams going on. And I'm just wondering, like our research summit feels like a really nice service station where we can all come together, share some food and have a chat about the things that are important to us. You know, we've got to find ways in this 5-track highway of when we can come together and share and refuel and stimulate our own ideas and have those conversations. So hats off to Alzheimer's Society and those people that have organised today, because I think this has been an excellent service station for us all to stop in. Thank you very much. Few acknowledgements, references, look, real research, and if you want to know more about meeting centres.
Okay, I'll introduce myself. Thank you. Right. As my colleagues from ESRC will know, sometimes the technology fails me, so apologies if I'm the one person today that can't press the buttons appropriately. So my name's Usha Bulaki. I'm the Assistant Director of Research at the Health Foundation, and I've come to talk to you today a little bit about not our research funding, which feels a little bit odd given my job title and the audience that we have today, but some of the work that we do across the foundation, not just in my portfolio, around the building of networks and some of the collaborative and cooperative mechanisms that we use to try and do some of this knowledge exchange, some of the translation, and some of the sort of systems thinking that people have touched on throughout the day. Oh, excuse me. I'm also battling a cold, so apologies if my voice keeps coming and going. So if you don't know of us, we're sort of one of those charities that people either have heard a lot about us or they don't know very much about us. We're an independent foundation, and we spend about £37 million a year on improving the health and healthcare of people across the UK. One of our primary goals as a foundation is to really make sure that the research and the evidence that we fund and that we also conduct in-house really connects between policy and practice. And what we're trying to do as a foundation is to think quite radically about how we use our funding to leverage real change across a number of different areas. We have 5 strategic priorities. I won't bore you with the details of this because I'm conscious I've got 5 minutes, but do look up our website if you want any more information. Perhaps most relevant for some of the things that we've been talking about today, we have funded a substantial amount of work over the years in terms of supporting healthcare improvement and improving the delivery and design of care. We're also increasingly looking at how we promote healthy lives for all, particularly the wider determinants of health, so things like social care plays quite a substantial part in that. And we're increasingly looking at the use of data analytics for improving insights around health and social care issues, particularly looking at data linkage and how we can really identify issues and insights that support that. We do it through a number of different mechanisms. We commission evaluations, we do directed research, we also fund implementation programs on the ground and use the evaluation from that to really generate and share learning and accelerate impact. We fund research in new areas, so we try very hard to fund in the areas that other funders are not funding in, to try and really think about tackling difficult and complex challenges. To some people, this might seem that we sometimes fund in the slightly riskier areas, but actually that's an intentional step that we take as a foundation. We're increasingly investing in large-scale initiatives. So although £37 million a year feels like an awful lot of money, when you weigh that against the totality of funding for the delivery of healthcare and the wider system of health and social care, it's a drop in the ocean. So we think as a foundation we can do an awful lot more by working in collaboration and working in networks with other funders and research organisations. And we work with and through external partners to make a bigger difference. Networks are an absolute fundamental part of the way that the Health Foundation works, and at a very conservative estimate, totting it up for today, I think we have planned something like £82 million worth of investment in networks across all of our strategic priorities over the next 10 years. We do this for some very fundamental reasons. One is about leveraging impact. We know that we cannot on our own influence entire systems by working in a single isolation. And we know that we need to be able to convene and bring people with the relevant expertise into the room to be able to discuss some of those challenges. We know that purposeful collaboration takes time and commitment, so we tend to fund our networks over a substantial amount of time. And we also believe fundamentally that if we bring together different disciplines, different perspectives from policy, practice, people with lived experience, we can actually bring together different perspectives and solutions to solve strategies around particular issues. So I'm going to give you 3 examples of the way that we fund and the reasons that we fund as you go into your conversations this afternoon. So one of the things that we've done over the years is fund improvement, which I've already talked about. But one of the things that we identified was one of the issues that were delivering improvement, particularly in healthcare, was that a number of the people that were doing the improvement initiatives on the ground were effectively operating in isolation. They might be based in hospital trusts or other provider organisations, and there may be one, there may be a small handful of them. And one of the things that we decided we were going to do is to try and create a community of improvers and connect them with both academics, with policymakers, with managers, commissioners, patient leaders, and many others to try and pull together a connected community of people who are trying to make significant improvements in care. We've committed to over 10 years worth of funding for the Q community, and we now have gone from something like 250 members to over 3,000 members from across the wide spectrum of policy, practice and service areas. We've put in a huge infrastructure underpinning this. So we have a central team. We also have regional network deliveries across both England through the AHSNs and also within the devolved nations. And we provide programmes of events, training opportunities and networking opportunities for individuals who are members of the Q community. And it is free to join up. So if you're interested, please do have a good look. We also think that actually, if we're going to see real change in the way that research and analysis is conducted, we probably need to start thinking about funding in a slightly different way. So one of our recent initiatives, which is, I think the applications have closed, but we haven't made the final funding decisions, is the notion of a networked data lab, which my colleague Sarah Deeney is leading on. And this is a collaborative network of data analysts and leaders across the UK using linked data sets to understand and address the challenges facing health and social care. The aim of this is that we're building an active community of data analysts across the UK to generate insights into key challenges. We think, because of the nature of the call, that it's probably the first of its kind. We're putting in quite a lot of infrastructure to support the successful teams when they've been chosen. And what we've asked for is a strong focus on engaging with patients and the public from the start to not just drive the broad research questions, but actually support the analysis as it goes forward, ensuring that the data is used in a legitimate and transparent way. We also use networks to support infrastructure. So we fund a number of networks. There's 3 on this particular slide. This is not the totality of all of the networks that we also support through our funding. We invest in a range of partnerships, and particularly in new networks that are looking to get off the ground, but also in terms of existing networks. We do this to leverage our impact, but importantly, we think we can't build capacity and capability on our own, and that it needs to be held within the sector and the expertise that you all hold to be able to do that. We use these networks to influence policy agendas through development of collective visions. One of the challenges you have within an academic sector is that you're quite often the structures which underpin it are quite separate. And some of the challenges we find as a funder that's trying to do influencing behaviours and policy and practice is how do you build that narrative and how do you build a collective vision. We also support a number of on-the-ground collaborations and networks to drive real change. So I'm not going to repeat this slide because Jill covered quite a lot of the left-hand column, as you will have noticed. But one of the things that we've done is quite a lot of research on what constitutes effective networks. And please, again, do look at our website if you want to find out more. I think given the conversation you're about to have and the questions that you've got on your table to discuss, a couple of things that I will focus on is on that right-hand side of the slide in terms of what to watch out for. So in our experience, there is quite often a set of optimism bias that hits a network when it wants to start to create itself, okay? People often think about what they want to achieve, how they want to achieve it, and the reality is that time and resource gets in the way. And it's one of those things that what happens is that it turns into a talking shop and it starts to drift. And that is a real and significant challenge with networks as they're starting to get started. And then there's another bit that you have to be really careful about when you're starting to think about developing a network. And it's the last 4 bullet points on that right-hand side. How do you stop a network from being part of a professional elitism, group of professional elites as they sort of move forward in their careers? How do you promote diversity into the room? Who are you inviting to help challenge your perspectives? What are you doing about breadth versus depth? What sort of network are you being? Are you a group that's creating connections, or are you actually wanting to make real change and really think about how you're doing that? And one of the things that's been picked up by colleagues today is about meaningful participation. So if you are thinking about inviting people who have experience of the services that you are looking to change or support or improve, how do you really get them to be able to participate in a network in a way that they feel that they can do and contribute to in a meaningful manner? So one of the things that I think is a foundation we would take away as a message is that networks are here to stay. As I say, we've committed to another 10 years worth of funding, a substantial amount over the next 10 years. And being part of a larger community really does enable connections. It does reduce isolation, and it can bring people into contact with a broader range of experience and expertise. It can build resilience through shared experience and speed up, that's meant to be, so apologies for the spelling mistake, speed up knowledge exchange through those soft connections that you develop over time. It does allow us to take a different view of problems and we've all been struggling with, and can provide a shared voice on complex challenges. I think you need to acknowledge openly that actually not everybody will benefit from a network equally. So being clear on what you offer and what you don't is key. And finally, the old adage, it's form that follows function, okay? And be clear on what you're trying to achieve.
So thank you for that. Our table leads have got the questions that are going to be addressed in this session. And then, as you'll know, I think we're followed by tea. So quick writing there. Thank you very much, everybody, and particularly to the speakers.